Hello, check.
Hello, good morning, everybody. Let's start this meeting with a word of prayer. Our Lord, thanks for the beautiful day given to us. Thanks for giving the health, wellness, and ability to enjoy our life. Help us not to take it granted all the blessings we have. Help us to be instruments of thy blessing and thy healing. Today, when we discuss the case, Lord, open our skills, wisdom, and let us share it. Help us to receive it and use it for the benefit of many. Be with us the entire quest today. In Jesus Christ's name we pray. Amen. Please be seated. Actually, I just want to welcome all of you for this quest. It's going to be an interesting case presentation today. And to introduce more and share, I request Dr. Hari Krishnan to have the next session, please.
Good morning, one and all. Myself, Dr. Hari Krishnan, Assistant Professor of Neurology. I welcome all of you to this special weekly morning academic session of BCMCH, The Quest. Today, we are going to have a different type of discussion, the clinical combined rounds. We will present a complex neurological case, which if not managed diligently would have resulted in a poor functional outcome and naturally has a very high mortality rate, maybe up to the tune of more than 70% mortality. So this young patient returned to her baseline after a very tumbling course in the hospital, which was essentially handled by our proper evaluation, excellent multidisciplinary care, and hitting hard. The pathology was hit hard by the appropriate medications from the pharmacological armamentarium. So this will be a very meaningful learning case for all of us. I welcome the speakers, Dr. Jerry, Dr. Vipin, Dr. Danny, Dr. Blessy, and Dr. Thomas sir. I welcome the chairpersons, Dr. John K. Jones sir and Dr. Jency Maria. Please be seated, sir. So let's all dive deep into this intriguing journey. I invite Dr. Jerry to start the case, the Mysterium Substantium album.
Hello. Good morning, everyone. First of all, I thank all of you for being here, despite the heavy rains outside. So this is Latin. This is the pronunciation is a bit different. I was saying how it is pronounced. So it is Mysterium Substantium album. So this stands for the mystery of the white matter. So we have a mystery of the white matter to solve, and let's start. So one of my favorite quotes from Sherlock Holmes, and I feel it is very relevant to our medical field. So it is a capital mistake to theorize before one has data, and insensibly one begins to twist facts to suit theories instead of theories to suit facts. So I have divided this presentation into many parts, and there are multiple speakers. So I'll be handing over the parts to one another. So first, we'll start with the arrival of the patient to the emergency department. So she's a 17-year-old girl. Apparently, she was normal one day prior to the onset of the disease, and one day prior to presenting to the emergency, she had headache and vomiting, followed by left-sided hemiparesis. It happened over hours. The afternoon, she started having headache and vomiting, and midnight, she started having this left-sided weakness, and there is also a history of preceding febrile illness. So, in the emergency, initially the neurosurgery team saw the patient, and the patient was not very stable. A CT was done, and they thought neurology opinion also should be taken, and I also was there. And she had a rapid fall in sensorium in emergency, and when she came, she was M6, and in a matter of 1.5 hours, I think she went into a comatose stage, became M5, and developed anisocoria in the emergency. So all this is happening in just 24 hours. Apparently normal child. And she was, our ED team came for help and intubated the patient and stabilized. And she was, we decided to go for the contrast enhanced MRI brain. So part 2, the image. So what did we see in the image? So I invite Dr. Danny to discuss the MRI.
Hello. Yeah, so I'm Dr. Watson then. If that was Sherlock Holmes, I'm Watson then. All right, so very good morning to you all. So as usual, the image holds a clue for everything. We started with a plain CT. This was a CT brain cuts in the ventricular section. And if you observe the image carefully, you can see a dark area in the right parietal temporal region. It's involving the cortical and deep cortical white matter. And it is causing a mass effect in the form of effacement of the ventricle, that's the right side of the lateral ventricle, with a mild midline shift. This was the plain CT taken. And based on this, we have advised a contrast MRI. On the following day, after a few hours, we did a MRI. Now, one of the baseline scans in MRI is diffusion weighted. This is a diffusion weighted image. We want to rule out whether an infarct is involved or not. So you can very well see there's no infarct. If there was infarct, there would have been a diffusion restriction, and we could see some ongoing infarct. After seeing this image, the next baseline image is flare. Now what you see is, you see a white matter hyperintense signals, predominantly in the white matter. You can see it is involving all the internal capsule, external capsule, as well as it is involving the thalamus, as well as the subcortical white matter and the cortex of the parietal temporal lobe. These are the coronal and sag images. And you can see it's also going towards the brainstem. And if you focus on the sag image, it is involving the corpus callosum. So next image which we took was whether SWI, that's in order to check whether there's bleed in this. And we saw there were minute microhemorrhagic process which was happening there. So there was petechial hemorrhages in this pathology. And we gave contrast to this. A contrast was not a typical pattern of enhancement. It was a peripheral patchy enhancement. It was not like a homogeneous enhancement. We didn't observe any meningeal enhancement. We didn't see any sulcal enhancement. But we saw an enhancement pattern like this, which was extending to the brainstem. So based on this, our imaging differentials which we gave 3 differential diagnoses. That is cerebritis, glioblastoma cerebri, or an aggressive demyelination. Now I would like to invite Dr. Vipin for part 3.
Very good morning to all of you. So, as Dr. Danny had said, we were really confused whether it is cerebritis, whether it is neoplasm. So, both has a different plan of surgery. So, I'll just review the images. So, when you see the images in the CT, you can see that CT images, you can see that there is gross uncal herniation, and the patient is in an impending uncal hernia. So we decided that patient needs early decompression. So next question is whether to go for a glioma, like take out the tumor or not. So this contrast, like Danny sir told, the contrast was there was contrast in enhancement extending from the temporal parietal lobes and going into the brainstem. So that is not a pattern for a glioma, like more against a glioma. So we thought of taking a biopsy. So we went in for, the plan was to do a decompressive craniectomy plus or minus lobectomy. So we went in for a decompressive, and this is just after the bone removal. To orient you, that is the frontal lobe and that is the temporal lobe. So you can see the brain is bulging out and the dura is like grossly, like highly vascular, and it is like oozing from everywhere. So this is just after durotomy. So I don't know whether you can make out the difference in color in that. I have kept a pointer where there is some color difference. And you can see brain is highly vascular, like grossly inflamed. So this is more against a glioma or a tumor process. It's more like an inflammatory process. So we had taken, so if you see these two areas, here there is a color difference. So we had taken biopsy from there. So this is post biopsy. We have taken biopsy. These two areas correspond to the hypodense areas which we saw on the CT scan. So this is the post-op scan. Sorry. So you can see in the post-op scan, the brain has grossly bulged out and the uncal herniation all have got resolved. So this bulging out of brain has somehow raised ICP, and patient initially had a like very bad course, and later on improved just because of we had done decompression. And I'll hand over the case for the microbiology people. And Dr. Blessy, please come.
Good morning, everyone. On behalf of my Professor Dr. Blessy Mary Thomas, I, Dr. Amrita, pathology resident, will be presenting the histopathological finding of this case. So we received this specimen, brain biopsy specimen, as multiple pale white tissue fragments, which aggregately measured 0.8 by 0.6 by 0.2 centimeters. On microscopic examination, this section showed multiple fragments of brain parenchyma, which was extensively infiltrated by numerous neutrophils. So this is the image that shows the brain infiltration by neutrophils. In addition, we also noted the perivascular neutrophilic infiltration and multiple foci of hemorrhage. So this is a low power view demonstrating the perivascular inflammatory infiltrate, that is the neutrophil, and areas of hemorrhage. And this is the corresponding high power view highlighting the perivascular neutrophilic collection and the area of hemorrhage. And taken together, all the morphological findings were favored for an acute inflammation that was consistent with the cerebritis. Thank you.
Hello. Let's see what happened now, up to now. So the patient came to our emergency department, stabilized, MRI was done. We saw the MRI findings. The neurosurgery team did decompression and stabilized the patient and bought us time. And because we haven't reached a diagnosis yet, still we are, but the patient is very sick. And usually the pathology gives a definite diagnosis, but here we just know that there is cerebritis, there is inflammation, nothing else. So what do? We don't have a definitive diagnosis here to treat. So we decided to go with a repeat imaging 4 days later. And if you remember the first image, you can see that it was only on the right side, and that MRI was taken just 4 days later. And just you can see how aggressive the disease is. So the other side is also completely involved, mostly involved. So again, predominantly through the white matter. So our theory. So when you have eliminated the impossible, whatever remains, however improbable, must be the truth. Another quote. So we have 3 differentials. One is, it could have been a malignancy, but the pathology has ruled it out. So that's gone. Could it be infection? Possible. Probable? We don't know. But we did one thing. Sir had taken samples for pathology and microbiology also. The tissue was sent to microbiology also. And I contacted the microbiology team. I rang them. And 48 to 72 hours, no growth. And no organisms identified, nothing. So reasonably, infection is also ruled out. So whatever remains must be the truth. It is probably immune mediated. So we came to our theory, and here is our diagnosis. It is called acute hemorrhagic leukoencephalitis, otherwise known as Western-Hurst syndrome. It is considered one of the most severe forms of what you call as ADAM. You might have heard of the disease ADAM. And I was reading about this. Up to 2016, the data, there is only less than 100 cases reported worldwide. So it's that rare. So with clinical radiopathological correlation only, we can reach that diagnosis. So now what we do? There are no guidelines. There is no guidance from anywhere. So treatment is solely based on case reports and just expert opinion. So we decided to go with immunomodulation. We gave high-dose methylprednisolone injection and also IVIG. But the patient is intubated in ICU, steroids, high-dose steroids. What happens? Patient developed infections, and we had to use higher antibiotics. And we waited for 2 weeks. There's no clinical improvement, no meaningful clinical improvement. So what do? We went for another course of high-dose methylprednisolone and IVIG, and this is not documented anywhere in the literature or anywhere. This was just our decision based on our discussions and the nature of the disease. And again, we had to use multiple antibiotics. The microbiology team, the infectious diseases team, the critical care team, everyone came together helping us. And there was multiple seizures. We had to use multiple antiepileptics in high doses. Patient had episodes of hypotension. We had to use anotropes. And another thing that we found was patient was having autonomic fluctuations. Suddenly the BP would fall. Suddenly there would be tachycardia. Patient would become unstable. So autonomic dysfunction, what to do? We were clueless. So we went through the literature again and found some data that gabapentin might be useful for autonomic dysfunction. And fortunately, after adding gabapentin, the autonomic fluctuations responded in this case. So that was also a learning. And of course, with other supportive measures, slowly she became stable, and tracheostomy was done, and we were able to wean the patient off. Now, what is the proof that our theory is right? So I invite Dr. Thomas sir to discuss and show us how the patient improved.
Okay. Again, good morning. Thanks for the narration. I think I feel like the treatment in any place should be like a relay. We hand over the batons. So luckily, most of the time, we get the last baton. So when we run, we see the final results. So the most important in a relay race is not the first person, second person, third person, is the final person. Because we bring the last relay thing. No, it's everybody is important. Anybody can fall, lose the baton. So they transferred the baton to us. We were lucky to see the last end of it. I still remember the day Dr. Hari called me one day and told, Thomas sir, oru patient undu. Archana na pere. Sir onnu take over cheyanam. Saithya cheytha pole onnu cheythu tharanam. I can hear the deep voice, his sincerity and his empathy to it. അപ്പം ഞാൻ പറഞ്ഞു സാറേ ഞാൻ എന്നെക്കൊണ്ട് കഴിയുന്ന ചെയ്യാം, ബട്ട് ഐ കനോട്ട് ഡു മിറക്കിൾസ്, ബട്ട് ഐ വിൽ ഡു. നോ സാറ് സാഹിത്യം എഴുന്നേൽപ്പിച്ച് നടത്തിയ പോലെ ഈ പേഷ്യനെ കൂടെ ഒന്ന് നടത്തണം. എനിക്ക് 17 വയസ്സുള്ള കുട്ടിയാണ്. So I went and saw this patient on tracheostomy, Riles tube, Foley's cath and everything, and in coma, complete coma. So finally we decided we'll take over. So on 21/5 we took over this patient and under PMR, but still we remain the patient in the neuro ward itself. GCS was E2B, T and M2 that time. And we initial thing, I'm not sure everybody is familiar with what the role of PMR, physiotherapy, occupational therapy, speech in these type of patients. So each one of the therapy has a different role in facilitating and stimulating the brain function. We believe in the neuroplasticity of the brain. Now patient is stabilized, we need to get them back to life. So first physiotherapy went in. The RLS score is a scale of the functional was 2 at the time started. And the time of discharge we could get to 8. Looked at the tone, if you can see it, it was like everything 1 plus, and the left was almost 0 power and tone. And patient was completely bedbound, and vitals were still unstable and connected to all cardiac monitor. The next phase I've given with the dates, like weekly basis, how patient progress. See, initially what they do is that they give passive range of motion to patient, don't develop any contractures or bed sores. And then the other focus was on something called a joint compressions, where proprioception is initiated, so the feedback goes to the brain. Electrical stimulus given to the muscle to maintain the properties of the muscle. And breathing, of course, is a big thing. Deep breathing exercise, chest physio, so they won't get congested. So towards the second week, the joint compression, everything controlled, and patient becomes slowly waking up. In this phase is what occupational therapists give a technique called coma stimulation. We have seen several patients waking out of the coma, much accelerated with this. And this process is called, we call this multimodal sensory stimulation, where they stimulate all the visual, auditory, tactile, and gustatory sensations next to the patient. So you might see they're brushing their hands, they're smelling the coffee, and they're giving different color lights in the eyes. They open their eyes and give different color. All these are called multimodal sensory stimulation. So this was along with the physiotherapy. At the bedside, the occupational therapist also was working to facilitate the proprioception and the sensory stimulation. One fine day, I remember they came running to me and told, sir, you have to come and see. The patient first opened her eyes. One eye was open, the right eye was open. These are moments we cherish. These are the moments we feel the best in our life. Not the salary, not the position, not what we are made. But when we see a patient who was in coma, open their eyes or move one toe when they're paralyzed, makes our day and our life. This is what cherishes. So first she opened the right eye. We ran and saw it. I was looking at the pupil, small constriction. The pupil reaction was there. And then it was a journey of amazing. In a few weeks, she started waking up. But for us to know that she went into an aggression. She was fighting, hitting, kicking. So I really hats off to the therapist who took care of her. They got a lot of hit, kicks, scratches, bites, every sort of personal injuries they received. But they didn't give up. You have to see some of the days they were holding her together, 2 or 3 people, that much she became agitated. And slowly she started calming down, and along with the occupational therapists, they were working on, because she couldn't have eye contacts and she couldn't have any coordination of movement. We started working on that. Then we saw working on the short-term and the long-term memory situations. Slowly problem solving. So from a fully bed-bound position, she started sitting in the bed, she started sitting in a wheelchair, but then we found she went into hypotension, orthostatic hypotension. So we went back again, we put her on a tilt table and started raising up slowly, weight bearing through a tilt table with vitals monitoring. And that was successful. We were able to get about 70 degrees in tilt table for half an hour. Then we know we have tackled the hypotension. Then she went into a wheelchair sitting position. Then a lot of reasoning, sorting, because she couldn't reason out. So almost like whole memory learning was wiped off. So it was complete a relearning process she went through. And then speech therapy came along the side. So primarily speech therapist works with the Riles tube and the tracheostomy tube. So the patient was already on Riles tube and Portex double lumen tracheostomy tube was inside too. Because the GCS was initially very poor, they couldn't do much. Once they improved, they started doing a lot of stimulation through the oromotor muscles. And then the cuff deflation is the first step they started doing. They see whether they can tolerate the cuff deflation and the stoma occlusion. And these trials were successful. Then they did a green dye test where it's a bedside like a swallow to see any aspiration risk is there. And then it was initiated on very thin liquids, then different semi-solids was tried in each week sequencing. And once the secretion reduced, with the help of the ENT team, we changed the Portex to a metallic, which is a smaller lumen tube on the tracheostomy. And then again, the swallowing test was done. When we find there is no penetration, aspiration, or pooling, we decide to take off the tracheostomy tube, close that. We caulked the tracheostomy tube for 24 hours. Then we were able to remove that. Once it is removed, and then slowly in a few days, the Riles tube was removed. Patient was taking adequate nutrition to the mouth. And once this has happened, then therapy, other things continued. The last success story is that yesterday this patient walked from the therapy room, came to my room by walking and tell hi, very happy. She told, I love walking. This is the best day of my life and I want to go home. And patient is near normal now. She just has some balance issues, some cognitive issues. I think we have taken the baton from them. We have first reached the finishing point and successfully we are handing over. I think this is a proud, proud case. We have to all feel very proud. But as I shared with them, sometimes we fail to celebrate it. And this is our second case in the last 1 month. Saite is the first case. We will discuss another case. Exactly same recover happened. She's almost near normal reach. She's gone back home. And Achin also will be going back in a few weeks home, almost near normal level. She has a little bit cognitive issues, some focusing issues. Otherwise, physically, she's almost normal right now. So we're happy, the entire team. And I think we have to celebrate and we have to let people know that we can do this with faith. I think it was a miracle healing happened at Believers. Thank you very much.
Hello. Thank you, sir. So I think we have solved the mystery of the white matter. And just before closing, just a few words about the disease. I already told that it is regarded as most severe form of acute disseminated encephalomyelitis, otherwise known as ADAM. It is usually post-infectious after bacterial or viral illnesses. And it is, as you can see, it is a very aggressive disease. And death is very common in the first week because many of these patients might die even before the diagnosis is made. Because here we were lucky enough that sir did the decompression, we were able to take the biopsy on the very first day actually, on the very first day. So there were some pivotal moments that decided the outcome of this patient. And this mortality is estimated around 70%, some say around 50, near 50, but the literature says around 70% mortality. And the mechanism is a hyperacute autoimmune reaction, where the others are the immune-mediated reaction. This is a hyperacute autoimmune reaction. And there's a difference in this case because if you see, if you look at the CSF, there might be neutrophilic predominance because this patient's CSF taken, so it was 500 plus cells with neutrophilic predominance, 90%, and high protein. So the pathology also, as they discussed, it is the neutrophils are predominantly seen, and there are hemorrhages in the tissue, and also there is astrocyte injury earlier in the pathology. That's also, there's also some difference between the pathology here. And there are no guidelines on the treatment. The literature says steroids, IVIG, and plasmapheresis are the options. But patient was not very stable, and we are not very confident with going ahead with plasmapheresis in this patient. So, and the repeated use of steroids and IVIG is something we did actually because we didn't have any other choice. So, fortunately, that worked out. So, when there are newer entities and newer challenges, how do we move forward? It is as a team, and I think this is a perfect example of collaborative teamwork. And this is the MRI image taken few days ago after 2 months of treatment, and you can see the left side, the lesion is almost clear, and the right side, a bit of that is there, and it might take some more time. And she is now talking and walking. Okay, thank you. Hope the time was worth it.
I invite the chairpersons for their comments.
Good morning. Thank you, Dr. Jerry, for this excellent case, all the team who has presented and who are actually involved in this management. Now, when you look at the case, within 24 hours of onset, less than 24 hours, the patient presented with anisocoria. Usually in such a case, we may think of a large hemorrhage with bleed or an intracerebral bleed. Here, the MRI shows simply mass-affected edema. So though there was anisocoria, so if there is a delay, definitely the patient is going to die with significant brainstem compression. Already there is brainstem compression. Dr. Vipin had shown that significant ungual herniation already existing. So one of the key factors in saving this patient's life was the timely intervention, neurosurgical intervention by our brilliant neurosurgery team. So we are so thankful that we have such a wonderful team to help us that saved the patient's life. Now, and subsequent, and also we had a biopsy, so that ruled out other possibilities, and we were able to go ahead with the right treatment. And of course, the multidisciplinary team helped further on. And this is the second case, as Dr. Thomas mentioned. There's another patient, Saitya, who also had a very good recovery. But then in that patient, the edema was not that profound, and we didn't have to go for the surgical intervention.
I would like to congratulate the entire team for the wonderful way this patient was managed. There are a few questions which I would like to ask. One is, somehow I still feel, could it be para-infectious than post-infectious? Because the acuteness within 1 day, neutrophils in the brain. What was the CSF finding exactly? Proteins high?
Yes, ma'am. CSF was 500 plus cells, somewhere around 511, I remember, and around 90% neutrophils were there, and the protein was high, about 300 plus or something. And
you managed to get some CSF during the surgery?
Yeah.
So was that also analyzed, the CSF analysis?
Yes, rest of the all, we did.
So biofire also was negative?
We did extensive investigations for all the infective workup. So what you see as the diagnosis, this is made after the whole lot of exclusion work.
So mycoplasma, all of them were...
So much of infectious workup. The tissue was sent to microbiology also, and we had requested to do even the rare organisms suspected anything, discussion with infectious disease, what we could do extra We are doing this exercise, and then nothing came up.
Yeah, because what I see is post-infectious, usually it is the herpes group of virus, EBV, cytomegalovirus, HHV6, herpes zoster, herpes, and chicken pox. All this can have post-infectious, and bacterial, it can be even streptococcal or mycoplasma or even TB for that as a post-infectious also can be there. Other thought process which I had was, what was the initial antibiotics this patient received? Did she receive any atypical cover also, like azithro or doxycycline or something at some
I don't
point?
remember exactly, but I think we had rotated many antibiotics.
Because one of
actually.
the rarest disease, I mean, presentation of rickettsial can be a hemorrhagic encephalitis. I was looking for all the infections which can cause hemorrhagic encephalitis. Rickettsial comes as the cause. All the others cause it as a post-infectious, like measles or mumps. All those will cause as a post-infectious hemorrhagic encephalitis, which again, it's extremely rare. So rickettsial, finally, the management had to be similar. Added with doxycycline in the beginning would have help the management. But however, this is an extremely rare case, and the way you have managed is excellent. Congratulations to the entire team. Anyone, over to Dr. Hari from the audience if they need to ask questions.
Anybody?
Hi, Dr. Jerry. I'm Dr. Aditya from MAT. What is your plan for steroid tapering in this patient?
No, we did not give maintenance steroids for this patient. We managed in another way actually. We gave repeated doses of high-dose methylprednisolone IV. We did not put that oral maintenance steroid for this patient.
Okay, so in continuation from that, as the imaging of this patient, the distribution of the neuroparenchymal process, was that compatible or typical of acute hemorrhagic encephalomyelitis?
Yes, exactly. If you see there are only very few case reports worldwide till now. As I said, I was telling maybe 100 or plus those case reports. But if we see the images, it is something similar, that it is an aggressive course. Within days, it will be bilateral and white matter and involvement.
Okay, so my question to you actually is coming from obviously my background.
Yeah.
Why was there was extension into the brainstem, the midbrain? So why was neuro Behçet's not suspected? And if it was, what workup did you do? And what about GPA?
Those kind of immune diseases, Behçet's, overnight in 12 hours presenting like this is extremely unlikely. This is this clinical profile doesn't fit that kind of presentation.
So that's not true. I see neuroparenchymal Behçet's presents like this only. But see, again, the lack of initial asymmetry, the extension into the brainstem, the focal nature of the bleeding, and the type of when they did the surgery, I was surprised that there was no contrast enhancement on the MRI prior to surgery of the dura.
No, prior surgery
there was. Okay, so that was not mentioned in this thing. So what about workup for GPA for ANCA vasculitis?
Immune workup also we had sent those. None of them came out to be positive.
See, the thing is that when you look at the biopsy findings, it is very prominently perivascular. There is definite neutrophilic infiltrate. Significant astrocyte or damage specifically doesn't seem to be there. Okay, and what appears to be the case is that it is a perivascular neutrophilic. When I see the biopsy, I would say vasculitis. So why not consider the possibility of neuroparenchymal Behçet's and also primary CNS angiitis, primary CNS vasculitis, because was an angio done at that time in the beginning?
No, angio was not done.
So again, without an angio, without digital subtraction angiography with the 4-vessel visualization, how can we be sure that this patient is not going to relapse?
We cannot say that 100% it is the patient might not relapse, but everything else is in support of what we have seen in the literature about Western Hurt syndrome.
That's exactly what I'm trying to say. There are 100 cases.
Yeah.
Okay. So it's a diagnosis clearly of exclusion.
Not exclusion exactly, it is clinico-radiopathological correlation.
Which means by exclusion, because you've done extensive IED workup for exclusion and you've done some immunological workup for exclusion. So what further, I would suggest you get a fundus fluorescence angiography done for this patient.
Yeah,
okay, review history for GPA, anything compatible with GPA and Behçet's disease, and also in close follow-up keep this patient, because if she relapses and again this entire thing happens, the entire process of rehabilitation and all will go down the drain. So
yeah,
in such cases,
thank you.
Thank you.
We will definitely look into that.
No. I have an answer to your query. You asked why this is Behçet. Actually, Behçet will produce something very classical of a meningoencephalitis and a rhombencephalitis rather than a white matter tract injury. This is extensively involving and confined to the white matter tract, initially localized to one side and then the white matter tract affected on the opposite side. Behçet normally will produce meningitis and encephalitis or maybe associated vasculitis. The classical manifestations in is brainstem, something called as rhombencephalitis. And here what happens is white matter injury along with microbleeds inside the white matter. So that is hemorrhagic leukopathy. This is not compatible with Behçet ideally. Yeah. Exactly. But what happens in neurovascular Behçet is there will be infarcts. There will be vasculitic phenomenology occurring in the brain. Here the diffusion is entirely not at all showing any cytotoxic edema. It is a vasogenic edema. That means the white matter edema is there. No. This is what you are seeing in the MRI as a diencephalic involvement is actually the edema extending or seeping along the white matter tract. It's not a direct involvement of the brainstem. It's not a diencephalic. The epicenter is something in the subcortical white matter. That's the epicenter. It's not a diencephalic pathology at all. Why the asymmetry happened is the patient presented very early into the course. And initially it mimicked a malignancy. But definitely one day, if the MRI would have done it 24 hours later, that bilateral pathology would have come. Yeah. Neurobehçet, the involvement is different, either vessel or a meningoencephalitis. The clinical history is not at all compatible with Behçet, and I think that thing is excluded fairly well here. The other thing which you have asked is the steroids and whether to continue therapy. Most of these diseases, such fulminant immune diseases of the brain, like CNS, this may be a one-time event or there is a chance for relapse. What determines this is the initial improvement. So this patient had a very good recovery from the initial treatment itself, and the MRI is not consistently showing progressive lesion. So that means the follow-up, the chance for recurrence is very less. Newer entities like MOGAD and NMO spectrum diseases all can present like this. There are multiple etiologies which can present like this. No, MOGAD exactly presents the same way, but what determines is the antibody positivity and the follow-up imaging. So what we are yet to see the follow-up images at 6 months, then only we will be able to know. And a repeat antibody testing at 6 months also will tell us whether to proceed with further immunomodulation. Regarding the oral steroids, based on our experience, what we found that was the continuing oral steroids or the tapering oral regimen may be inferior to a weekly pulse of IVMP. All the side effects seen with oral steroids are almost ameliorated with this weekly IVMP pulse. So weekly IVMP pulse is an alternate regimen I think we as neurologists are going more towards that. No, see, that's the protocol. I think rheumatology protocol may be different. Because the pathology was not showing vasculitis. It was just showing neutrophilic infiltrate. In the white matter, whatever the tissue was taken. Yeah, in the tissue, in the interstitium, in the neuro, this astrogloid tissue. Yeah, that's not a vasculitis now. There is no fibrinoid necrosis or anything in the vessel now. Yeah, thank you so much. I think we can conclude the session. I thank all of you for attending and contributing to the session. Thank you.
I want to congratulate all those who thought through this. It's a new terminology, clinical combined rounds. So shall we give this whole team a big hand? Because I don't know whether you all know, Jerry is popularly known as Django from the All India Institute. So he did all that just now, the Django-ish. He taught us about Sherlock Holmes and Watson and all that. But that's the excitement of clinical medicine, isn't it? That we don't know what it is. They made the diagnosis, and then the neurosurgeons came in and did what was necessary, and then the physical medicine rehabilitation. So at the end of it, we have a fantastic result, but we also have gone through the stages of learning. So Django, thank you very much. Harry, thank you very much. So I hope we'll have more of these combined clinical rounds, because there are lots of patients like this, because we now become a referral center. You're getting a lot of clinically difficult cases to work out, and then surgically difficult. So can we have more of these things? Thank you. Thanks very much.
Thank you, everyone. Today we could finish in time. We started early. So see you all next Thursday. Thank you.